a, a copy of the link. Please feel free to share it with others. And it's also available on our website. So look forward to that. And with that, I'd like to I've already introduced myself, Tina Doty. I also want to introduce our host for today, Jeanette Picker. She is the secretary of our league, and she is also somebody who works at Camino. So she's very aware of how important this work is in our community and also very dedicated to people in San Mateo County. So we're grateful to have her, and we're grateful that she was able to help us put together this program. So with that, Jeanette, I'll turn it over to you.
Thank you, Tina. Good afternoon, everyone. It is my pleasure and honor to introduce my colleague and our speaker, Mark Cloutier. He's been serving as CEO of Caminar since 2019. Mark has dedicated his career to increasing access to quality health and support services for under-resourced communities and improving the overall health and well-being of individuals and families. He brings to Caminar extensive experience in organizational leadership, fundraising, financial and talent management, public policy, and strategy development. Prior to joining Caminar, Mark held leadership roles in major health organizations and foundations, including Horizon Services, the San Francisco Foundation, the Center for Youth Wellness, Kaiser Family Foundation, and San Francisco AIDS Foundation. As CEO, Mark leads a $49 million organization of close to 400 employees that serve more than 41,000 people last year in San Francisco Bay Area and Northern California. A long-standing Bay Area resident, Mark is a graduate of the Lewis and Clark College and earned his Master of Public Policy and Master of Public Health degrees at the University of California at Berkeley. He has authored a number of articles and co-authored Prevent, Screen, Heal, Collective Action to Fight the Toxic Effects of Early Life Adversity. Mark also serves on the board of directors of Tenderloin Neighborhood Development Corporation. So that's my introduction for Mark. I just want to let you all know that at the end, we will have, after Mark presents, we will have time for question and answer session. And please enter any questions you have along the way in the chat, and we'll answer them at the end. And I will hand it over to Mark.
Thank you, Jeanette. Thanks for that introduction. And Linda, thank you for inviting me. It's wonderful to be here, and I'm glad we are talking about this issue. I want to just tip my hat to the League of Women Voters for helping to create a civic culture of participatory democracy. We're in a period where engaging around our public issues and using our institutions and strengthening them are even more important. So I'm very grateful to the work that all of you do. Next slide. Next slide. So I want to talk to you first about the situation that we're experiencing in the Bay Area. And the Bay Area is really a microcosm of the whole country. We're experiencing a behavioral health crisis in our region. And a crisis is an interesting way to define it. Crises are usually sudden changes that cause some sort of extreme condition to occur. And we've actually been having a very slow, gradual crisis that actually came to a really critical point in the COVID-19 pandemic. And part of what that is about is that for adolescents and young people, they were living at home, not attending school, going through a developmental epoch in which they were very typically very dependent on being in the physical proximity and with each other to help develop an identity, to separate from your parents and to figure out who you are as an adult. And that didn't occur because people couldn't leave their homes. They were connecting through Zoom. They were connecting through social media, which made adolescents actually more dependent on social media during that time. And we since know that social media has, for many young women, had negative mental health consequences, including worsening body images, a sense of isolation, depression. It did not contribute to good mental health outcomes. And that's really been an untreated issue that we've not been able to address. And that kind of experience and those disorders actually that got established are still present for many young people, and we're unable to treat all of the young people who need care. And I'll be diving into that into some more in some more slides. But one of the issues that we face too, despite innovation, and I would refer primarily to accessing mental health through telehealth methods such as Zoom or mobile-based treatment, that there still is a significant treatment gap. And that has to do with healthcare financing. It has to do with the shortage of a trained behavioral health workforce. And it has to do with general kind of dispersion of where the problem lies in terms of where people who need services lie and where the treaters are. So I want to use this as an opportunity to focus on finding some solutions together, and what we collectively between organizations like Caminar that are doing community-based mental health and organizations like the League of Women Voters can do to improve mental health in our community. Next slide, please. So we are, as was described by Jeanette, we are a large regional provider of behavioral health services in Northern California. We operate in San Francisco, San Mateo, Santa Clara, Solano, Butte counties, and offer a variety of services that include therapy, psychiatry, residential care, substance use recovery, and school programs. So we take a very unusual approach to mental health care services, in that we don't just provide clinical services, but we do wraparound services that include addressing people's income needs, their housing needs, their social needs, and of course, their behavioral health treatment needs. And we also focus on unmet needs of poverty, racism, and trauma that we address in our whole person and culturally competent trauma-informed treatment that we provide. Next slide. So I talked about the crisis that occurred during the pandemic, and what that's led to is that about 1 in 5 adolescents, about 20%, experience mental health disorders annually, which adds up to a significant amount of prevalence in the population. The most common disorders that are diagnosed are depression and anxiety. And as I mentioned, COVID-19 contributed to that in a very substantial way. But we're seeing a substantial increase that went from 18% in 2018 before the pandemic to 27% in the middle of the pandemic. And clearly that's continuing to grow in an upward trend. Next slide. I also want to acknowledge that there's significant substance use prevalence among adolescents, and the most commonly used substances are alcohol, cannabis, and vaping. Recent statistics show that about 30% of adolescents use alcohol, 25% cannabis, and 20% vape. And I just want to distinguish use from abuse. So this is merely citing use. I would differentiate abuse that leads to what I would describe as substance use treatment disorder is significantly less than that. But the important thing here is the value of early intervention through education in schools and through early treatment to address the presenting early symptoms without causing people to go on to severe substance use or mental health disorders. Next slide. Commonly, 30% of youth have co-occurring disorders. That means that they have both a mental health and a substance use disorder that happen at the same time. Just taken separately, 50% have mental health only and 20% have substance use only. Co-occurring conditions can be very complicated to treat in that you're treating both kind of simultaneously. And frequently you start with treating the mental health disorder in order for someone to make progress on being able to understand and manage their substance use disorder. And in the end, the most effective forms of treatment are integrated care that include medicine or primary care, mental health, and substance use treatment that may include behavioral treatments. It may include medication-assisted treatment, and it will probably include some form of cognitive behavioral therapy. So let me just pause. I've been going quite fast. Just ask if there's any questions about what I've said. I see there's in chat. Any
Yeah.
questions?
I haven't seen any yet, Mark, but if anybody in the audience has any, please feel free to type them into chat and we will answer them at these breaks or after Mark presents.
Next slide. So I want to describe where the primary prevalence is, and prevalence is the persistent persistence of a disease or a condition in a population. So LGBTQ plus youth experience a 40% prevalence of mental health challenges, which is significantly higher than the general population of non-LGBTQ youth, in which it's about 20%. So LGBTQ youth are 2 times more at risk of developing mental health issues. Also, kids of color, Black, Latinx, and Native American youth show higher prevalence rates of mental health issues compared to the 20% general rate in the population. And because of that, these populations need customized, tailored interventions that understand their language, their culture, their norms, their practices, that nests treatment in those cultural practices. Next slide, please. So what's causing this prevalence to occur and causing it to stay high? One of the things that is the most challenging is that there are long waiting times and provider shortages that allow people to get into mental health treatment. We have a shortage of people who are trained at the right credential level. We have a shortage of people in particular who are prepared at the master's level. There's a lot of things driving that. One of them is the cost of getting a master's degree and being able to afford the loan payoff while paying rent in the Bay Area. It discourages a lot of people from going into the profession. I mean, the cost of housing also keeps people from being able to locate close to this area. So there's a particular shortage in the inner Bay Area. The other is insurance gaps. There are many people who are uninsured, and even for people who have traditional insurance, there may be limits based on being in a provider network, the number of treatments that people can have, utilization management, and then just an episode of care sometimes is just limited to 4 or 5 or 6 treatments. And even though the person may not have resolved their symptoms, the treatment comes to an end by the insurance company. The other is disjointed treatment between mental health and substance use treatment, as I mentioned. In Medi-Cal, which is the primary financer of our services, you have to treat people separately. You have to open up different medical records, and you have to have a different course of treatment and a treatment plan that's not integrated by design. So fragmentation is a big problem in the system. And then there's other issues about lack of access in some communities. There's a lack of insurance coverage that particularly persists in low income and communities of color. Next slide. So adolescent mental health in California. So 15% of California youth had major depression last year, which is up 1.4% from the previous year. Critically, most of the kids who have depression do not receive any kind of mental health treatment. And again, that goes back to what I was talking about previously. Insurance coverage, lack of people who are trained to provide it, and then geographic distance. The growth in anxiety and depression have increased about 70% since 2016 across California. Again, much of that was driven by the pandemic. And most concerning is increasing suicide attempts. That's measured primarily in emergency room visits for suspected suicide attempts, which for girls 12 to 17 rose by over 50% since 2019. Really alarming statistic that should get us all mobilized. So as I mentioned, there are funding shortfalls. So one of the things that is happening in a third of the people in California have their health insurance through Medi-Cal. Medi-Cal raises rates at a rate that is slower than the cost of the inputs. So I'll just give you an example. The rates that we get paid for an hour of psychotherapy went up 2% this past year, even though the inputs, the cost of labor, the cost of leases, the cost of training, the cost of utilities went up over 18%. So there's a funding shortfall that's causing behavioral health services to be constrained. As I mentioned, there's a lack of qualified mental health professionals, fragmented care delivery. There's a problem of not integrating mental health and substance use treatment. They're treated in two separate domains. And then lastly, because of these cuts in insurance rates, facilities are closing. So it's causing further access issues. There's limited treatment access, as I mentioned, especially for adolescents and justice-involved individuals. One of the programs that we operate is a program called STEP that helps people who are in prison or jail and provides treatment while they're in jail and then supports them when they're released and when they re-enter the community. There's an important issue of continuity of care when people are transitioning across institutions. Integrated care is, again, a really important aspect of that, the integration of mental health and substance use treatment. And that there's an important expanding treatment approach that includes medication-assisted treatment, which is the most common versions of that are naloxone or buprenorphine to treat people who have opioid disorders. There's naltrexone for alcohol addiction. And ketamine for depression. So increasingly, we're looking at using different kinds of substances to treat addiction as a way of titrating people off the drugs that they're addicted to help them move towards sobriety. Next slide. So I want to talk a bit about Medi-Cal, that Medi-Cal is really a critical part of treating community mental health in the Bay Area. Medi-Cal in the Bay Area covers about 40% of people. It is very comprehensive. We offer a lot of our services to people who have Medi-Cal. In particular, the benefit is the best for people who have severe mental illness. It allows for treatment of psychiatric disorders. It provides case management, psychotherapy, residential treatment, and housing supports. And as I mentioned, there is a very low reimbursement rate that is challenging us to provide services. We had to close a number of programs last year because the rates for the services went substantially below what the cost of providing direct care actually was. Fortunately, there's some good there's some good initiatives that have recently passed. Prop 1 was on the ballot 2 years ago. It led to the establishment of a $6.38 billion bond fund to allow behavioral health treatment capacity to be expanded statewide. It's allowed for the building of inpatient facilities and then residential treatment for people who have substance use disorders. The hope is to create 6,800 residential treatment beds and an additional almost 27,000 outpatient slots to meet unmet needs in the community. The funds are also used to target housing. Much of this is going to be used to develop housing for people in particular who are vets. Vets comprise a large portion of the multiply diagnosed homeless population who have substance use and mental health disorders. And this will allow for housing to be developed for that population. Next slide. The other big initiative that's occurred is the establishment of Care Court for adults. It was largely established to assist the members of the community who are largely homeless, living on the streets, and who have severe mental health disorders that include primarily schizophrenia and people with other serious mental health disorders like bipolar disorder. And it allows them to go through a process in which they're mandated and provided housing, medication support, and behavioral health and substance use treatment services to help them in their recovery. And it's a novel approach that includes court oversight with behavioral health treatment to support voluntary treatment outcomes. Next slide. What can the League of Women Voters do? One of the things is continue to advocate for increased funding for services. I talked about the funding for Medi-Cal is declining. There were changes that were in the HR 1, the big bill that passed about 4 months ago that is causing a number of facilities to have to close because the funding gap. It's also causing a number of people to lose their coverage. And as you know, related to the government shutdown, it's causing a lot of people to lose their subsidies. So the issue is that a lot of people who are previously have insurance are going to become uninsured. The other thing that League of Women Voters can do is to support early intervention and treatment in schools. There's a question in chat. There's a number of things that have happened in schools over the last 5 years that have bolstered support. There are actually therapists in schools. There's psychoeducation that's being provided in schools and evidence-based intervention to treat trauma in kids in schools. There's a way of looking at curriculum and redesigning it from a trauma-informed perspective that has also come into schools. And lastly, there's support for administrators and teachers to help their mental health in order for them to be more present and able to educate their kids. The other big issue is policy efforts to support parity. There was a bill passed many years ago in the Congress that required that mental health treatments be treated and paid for in the same way that physical health treatments are treated, and that still has not come to fruition. There's still a disparity between mental health treatments, for instance. I'll give you an example. The mental health treatment for an hour of psychotherapy, which is about $85 compared to the hour of a primary care visit, which is approximately $210. We need to improve parity so that mental health insurance rates go up for organizations that are providing care. The other very important thing is to talk about mental health. And really, it's to talk openly about your own mental health with your family and with your friends to make the stigma go away and to normalize being able to talk about mental health in public. The other important thing is to support whole person care. And that's really about integrating primary care that includes mental health as well as the social determinants of health, such as housing, food, and income maintenance. And lastly, and very importantly, what you can support organizations like Caminar by donating to us, joining our board, volunteering, and supporting our social media posts. So I will pause there and open up for questions.
Okay. You have elaborated on our school programs. Is there anything else that you want to add to what you've already said, Mark?
I would just say that in general, we take an approach to treating the whole person. Again, so we're not just doing the mental health and substance use treatment services, but we're treating people's housing issues. We're dealing with people's food security and dealing with income maintenance, and that's a model that we deeply support.
Mm-hmm. We also have programs from elementary all the way through College of San Mateo. Is there a rural versus urban disparity, either in terms of resource availability or in terms of disparate care needs?
Both. I think, there's a general, there's this measurement of psychiatrists per zip code. And it's very clearly there's a profound shortage in rural zip codes. So people in rural areas often have to travel long distance to get mental health treatment services because it's simply not available in their community.
Okay, and what are the threats, hang on, to Medi-Cal in the current shutdown and in the proposed continuing resolution?
Thank you for that question. So the shutdown, the good news is that payments to providers continue to happen during the shutdown. Medi-Cal, actually all the entitlement programs, Social Security, Medicare, and Medicaid, and Medicaid in California is Medi-Cal, all are preserved and operating during the shutdown. But the issue that's going to happen is because of the changes in HR1 that are happening around the Medicaid program, people are going to be losing their subsidies on the exchanges. And there's also the ability for providers to raise more funds by essentially, it's a device where they tax themselves. The state then sends that up to the federal government that matches whatever the state raises for Medi-Cal at 50% and then returns it to the state to pay providers. That has gone away in HR1. So there's a number of aspects in that bill that is going to further reduce funding for Medi-Cal services.
Thank you. And from our President Tina, can you speak on how these services can be cost effective for communities? How do things like early intervention or services actually offset other costs?
So I'm going to talk about this at the macro level. So there's an estimated $3 trillion loss of global productivity due to untreated mental health and anxiety disorders. That's a World Health Organization statistic. I don't have that broken down by our local area, but basically, untreated mental health not only causes human misery, it not only causes failed marriages, failed relationships, lack of school attainment. It significantly affects people's work, their absenteeism, their ability to do their jobs well. And the cost of that is enormous to our economy. And it's in aggregate much cheaper to provide access to treatment for everyone for sufficient and sufficient time for their treatment symptoms to abate rather than have untreated mental health issues simply due to the loss of productivity.
Thank you, Mark. And Suzanne asks, how does Caminar differ from services provided by San Mateo County Behavioral Health? Is there overlap? Is there cooperation?
There's a good bit of overlap. They are a primary provider. They are who we have the majority of our contracts in San Mateo with. So actually the whole San Mateo mental health system is a collaboration between the county, the county that operates both the insurance system of Medi-Cal, but also provides its own services directly as a provider, in conjunction with community-based providers that, like Caminar, that also provide a significant number of services in the county. Actually, the majority of mental health services in the county of San Mateo are provided by community mental health providers, not the county itself directly. What other questions can I answer or discussion points?
From Linda, there is an inherent difficulty in getting support for service costs due to the lack of objective outcomes. So it's easier to see polio go away with a hot versus depression over a long time. Is there something we can do about this?
I love this question, Linda. Thank you for asking it. And you're right. I mean, the one difference between mental health issues, although substance use issues are different because there are biomarkers that you can measure. That's what's true in medicine. However, you can administer pre and post tests or assessments of people describing, subjective things like reduction in depressive feelings, in days of school loss, days of work loss. There are very objective ways of measuring outcomes. Also, you can also measure the reduction in emergency room use. You can also measure the reduction in homelessness. So there are ways to measure mental health treatment. It's a growing science. It is quite subjective in that most of it relies on the patient doing their self-report, but there are rigorous methods for doing that. Other questions or comments?
Eileen asks, does Caminar provide employment services via Department of Rehabilitation?
We do. We have but that is in Solano County. We have a contract directly with San Mateo County to do vocational trainings that prepares people, trains them, counsels them while they're in employment. So one of the wonderful things that happens is not only do you get training to be able to go to work, but we support people while they're at work, because it's often an adjustment for people who've had a long history of mental health disorders, to get their first job and to be able to be successful at that first job. So I'm looking at one of our employment counselors, Joseph Lazaro, who's on the call with us, who helps with this work with our clients in San Mateo County.
Mm-hmm.
Other questions?
Linda asks, is there a comparison of overall well-being between the pre-Reagan years when mental health had more government support and now?
So I think you're referring to the volume or kinds of services as opposed to the distribution of conditions in the population in those two periods. Is that? Yeah, I think yes. I would just say in the state of California, starting with the Mental Health Services Act, the so-called millionaires tax that was passed many years ago, probably about a dozen years ago, that there's been a number of initiatives to increase funding for mental health and substance use treatment that has grown since the 80s. So I think I don't have measurements of it, but there is much more treatment available now than there was in the Reagan era. More questions. And you know, President Reagan was very famous for, I want to draw a connection. One of the things that Reagan did as governor, which was a good thing and a bad thing, you know, previous to Governor Reagan, there were institutions of mental disease that were basically storehouses for people who had severe mental health disorders. People with severe mental health disorders were essentially committed to facilities, and those facilities were very inhumane. People did not get care. They were heavily medicated. There was not a lot of behavioral health treatment. The governor closed those facilities. The bad thing is it led to a number of homeless people who are mentally ill. The good news is it led to the expansion of community mental health treatment in the community, and that actually the Mental Health Services Act that led to Proposition 1 and the bond measure that allowed for the raising of funds to build new inpatient facilities and new residential facilities has its lineage going back to the Governor Reagan closing mental institutions. So it's been a long course of correcting that mistake.
Mhm. Christine asks about that Prop 1. Can you elaborate on the aspects of it? And it sounds like some, for instant housing, will take a long time to take effect.
Yeah, I mean, the funding's available. The funding, I believe, has been dispersed. There's been round one of funding. And then the issue is, of course, the time of zoning. I believe it takes about 7 years from start to finish to build a unit of housing in the Bay Area. It's just elaborate environmental zoning. I know that got recently changed through legislation, that the EQA restrictions got loosened. But the issue is not the amount of funding. The issue is the regulatory process that it takes in order to build housing.
Mhm. And Linda asks, what are the tenets of community-based mental health provisions?
The tenets are really focusing on the client. It's client-based care, that you develop a treatment plan in conjunction with the client. The client defines what outcomes they want to have, and get to select the kind of treatment that they want, and then collaborate with the provider in the care.
Really great questions so far. Suzanne asks, do you provide any support for families who have members with mental health challenges?
Yeah, as part of the work that we do with people with severe mental health, we provide family support, and we actually conduct groups for them. And then for people with mild to moderate disorders like depression or anxiety disorders, treatment with the whole family is often part of the whole treatment model. What other questions do people have? Or any comments that people want to make, or any discussion people want to initiate? Regional centers are usually for people with we do get them in particular from vocational training. Yes.
Do you have any tips for getting people to talk more openly about mental health?
Put a toe in the water talking about your own mental health. I mean, you can you can just share with people what your mood state is, and or talk about what challenges you've had over the course of your life, or um, and use that as a way of dipping into talking about mental health issues.
Okay, and Tina asks, the League of Women Voters of California actually opposed Prop 1, lower funding for local services, involuntary hospitalization, etc. My conversations with family and providers supported the prop. What are your thoughts about the legislation overall impact, and how would we address these concerns?
So I will go back. Great question, elaborate question. I would just go back to the conversation a minute ago about the lack of facilities, the lack of providers. Critically, the state had a dramatic shortage of inpatient treatment for people with severe mental health disorders. And it's particularly true in San Mateo County. There's a real shortage. We get referrals from the county that are people with very complicated, complex mental health and medical conditions that should be in inpatient facilities, that Prop 1 will be able to support by building of those facilities. So it's kind of a trade-off in populations is what I think of the effect of Prop 1. Prop 1 is really addressing people who are severely mentally ill, people who are on the streets, people who need to be in facilities. They can't benefit from community-based mental health care because they don't have consistent housing, or they have a condition such that they can't manage their own ability to get in care and stay in care. So it's a bit of a trade-off of addressing the complex needs of the people who experience the worst mental health symptoms and consequences for people who are more in the mild to moderate range, who may have lost some education or early intervention services. Ideally, there'd be money for both, but this was a trade-off and a shift in where those monies were going to go. But I really appreciate the question, Tina.
Linda asks, is the lack of psychiatry trained people worse in California than other states?
I don't know. I know that this is not going to be a surprise. There's a concentration of psychiatrists in areas around medical schools. That it's right. That makes a lot of sense. So insofar as we do have a lot of medical schools in our state, I would think that we'd be near the top of rankings as a state of psychiatrists. Other questions or comments? I just want to kind of not close, but gently ask the question, having heard all this, what do you think you can do to improve mental health in our community? What are some thoughts that people have? And I provided some tips in my last slide.
I saw Linda speaking, but I didn't hear her. Did you want to unmute? There you go.
I was saying people should feel free to unmute themselves if they'd like to respond to Mark and talk a little bit about what their observations are. Jean, I see you're online. I know you have a lot of interest in this area. I'd be interested in your thoughts and observations, and anyone else who wants to speak up.
Hi, it's Tina. I would just say I think there's some education that's needed for voters to understand kind of what the situations are for people who are dealing with these issues. Both kind of people who are caregivers, people who are providers, people who are in need of services. Because I don't think the image that people have necessarily matches the reality that you're talking about.
Right. Right. And Tina, I just want to restate one statistic that captures much of that I want you all to remember, that about 20% of adolescents have a mental health condition. Only 60% of those get treatment. So we have this huge growing problem that will track into adulthood. And fundamentally, this is so important for the League of Women Vote. Fundamentally, it's a public policy issue. It's an issue of funding. It's an issue of priorities. And it's an issue of our, treating kids so that they have a healthy future.
And Jean,
I
you have your hand.
Sure. Two points I'd like to hear your viewpoint on. One is that the closure of many programs was due to the lower reimbursement rate.
Correct.
And that there doesn't seem to be any compensation for high expense areas like San Mateo County. So in many ways, I think our county was hit worse by simply there is no way that someone could support themselves, and there's no way an organization could support themselves on the rate of reimbursement. And the second thing I'd like you to address, if it doesn't leave my mind here, is the value of peer support. And of course, certified peer support specialists do earn more than minimum wage, but the value of them is much more than minimum wage in terms of peer support has been found to be a hugely valuable thing across the range of behavioral health services. And how do you see with the reimbursement, where is the muscle to try to change that so that the people don't have to rely on food stamps if they want to work in this endeavor, and what can we do about maximizing the wonderful effects of peer support?
Really great questions, Jean. I really appreciate it. So you're right. There is a bit, the rates that we get paid are based on a formula that in part include the cost of inputs in the county. But you made a correct observation that it does not sufficiently account for that, such that the rates in high cost counties like the urban county, San Mateo County, Santa Clara County, Los Angeles, San Francisco do not match the cost of the inputs. So it's just a public policy issue that we're just going to have to continue to kind of raise to our members of Congress and our senators that the reimbursement rates need to reflect the actual cost of providing services. Otherwise, we're going to have a severe shortage. Certified peer specialists are amazing adjuncts to therapy. You know, they're not a substitute for a trained clinician, but one of the things that's most important is that peers can see what's being prescribed, what's being treated, the dialogue and the support for the patient through their own lived experience, and can support the patient as a peer who's had the similar life experience to them. So there's a level of empathy, there's a level of understanding, there's a level of support that peer specialists are in a very unique position to provide, and they have an amazing extending effect on treatment. Thanks for the question, Jean.
Jean, you're muted.
I'd like to add that you mentioned family support, and many of us are familiar with the SAMHSA guidelines. It may have been disappeared by our current administration, but SAMHSA is a treasure trove of what are the evidence-based practices, what supports recovery, where you need to put your buck to get the most bang, and definitely supporting a person in having recovery. There's no question that if there's family available or a family of choice available that is on board, that is huge. So I volunteer with NAMI, and I teach the family to family classes, and and I think our community is, in spite of support groups, which maybe are once a month, and there's probably a support group almost every day of the week, whatever, for peers and less so for families. But how do you think we can enhance family support for their loved one? Very often, at the point where someone is hospitalized or even institutionalized, there are a lot of burned bridges.
Right.
And helping families know where to begin so that their relationship can be repaired, so that they can begin to have mutual trust, so that they can be a step in the individual's recovery. So how can we support that?
Well, you just kind of answered it yourself, which is an important part early in a treatment plot process is to help a person reconcile to the damaged relationships they may have had along the way in order to get that kind of family support or community support. So it's a critical part of the therapeutic process. It needs to happen closer to the beginning. And I think any good model of treatment includes that as a primary focus.
Well, my understanding is that Caminar only has one family peer support specialist, if zero, maybe zero now. And when you consider how many clients you have,
Yeah,
that seems a very low proportion to provide the appropriate amount of support.
I think we have a couple actually, Jean, and it is based on the reimbursement and the evidence-based intervention and the proportionate staffing that we have in that model. We would like to have more, and the model's not set up to reimburse that way, regrettably.
So what can we do about that?
I think again, it's a policy matter to advocate more family support in the rate, in the Medi-Cal rate.
Our behavioral health director has been a very strong advocate on the state level to try to budge the reimbursement rate for the high cost of living in San Mateo, and that's with all the statewide, the directors of behavioral health. And it sounds like it's nothing more than a discussion. It sounds like there isn't any power in that discussion from our side of the equation.
Yeah, I think Dr. Africa is doing, I think he's advocating with his colleagues, the California Behavioral Health Directors Association, to the state Medi-Cal program. And ultimately, that's where there's going to be relief at the state level. And the states also California needs to advocate up to the federal level also about, it fundamentally comes down to the formulae that they use to devise rates. And the cost of living in the Bay Area, as you noted, is much higher, and that needs to have a significant multiplier effect in the rate in order for the rates to actually address the cost of providing care. Sounds a little dry, but that's really what it comes down to.
Thank you.
So I think that the original question was, did anybody have ideas? And honestly, I'd really love to hear ideas of things we can do either personally or as a league to help support mental health in our community. We're all heading into Thanksgiving. And I don't know if this is a better topic, but maybe rather than politics, which is somewhat fraught right now, maybe conversations about things of this nature to help destigmatize how we're feeling might be a way to start.
This is Linda. I had a thought as well that on the issue, Mark, you bring up some compelling logic about the price we're going to pay for particularly the rise in adolescent mental health conditions, and that if we had, simply said an elevator speech or something that could make it clear to the folks we talk with that this is an important community civic, issue that we need to attend to on the same level that we might attend to I don't know, crime rates or homelessness. We all have to think through those, and a lot of times they're related, but I think connecting the dots would be really helpful. One of the things as we built this meeting, we began to realize, and you must see every day, is people are reluctant to talk about mental health in their own lives, and they're reluctant, as a result, don't always understand how prevalent, the issue is for many of the people, their neighbors and their workmates and other things. So I think connecting the dots and getting a way for all of us to tell a compelling story as we move through our networks would be really helpful.
I think if I could just add to that too, I think personalizing a bit and particularly talking about experiences of people whose life changed as a result of getting treatment, because I think a lot of people wonder how well it works. And I think that's one of the major inhibitions. The other major inhibition is, of course, stigma, acknowledging that it even exists. So 1 in 5 adults over the course of their life are going to have a diagnosable mental health condition. And then I would just remind people about the number of untreated adolescents, and then the issue of the lack of treatment and its effect on economic loss and people losing jobs, not obtaining their educations, marriages, family dissolution. The cost of not treating people is substantial. Not to mention the human suffering that happens. Well, I just want to, if we're done, I just want to encourage people. Caminar is in our community. We appreciate your support. We're always looking for board members. So I've had a lot of this conversation has been really rich. So I see a lot of good thinking that would be interesting to have in our board. So that would augment the conversation that we always have on our board.
Well, I want to thank you on behalf of Jeanette and everybody else who's here, and on the behalf of our league, thank you for telling us about what you do. I didn't know that Caminar was working in our area. Glad that you're here, and yeah, this is what Linda often says: when you keep showing up to our meetings, you just know things that you wouldn't know otherwise, and you suddenly can become the expert in the room just because you were here today. Before we end our meeting, let's see if I can do this correctly. I did want to share just a few things about what's coming up. Oops, that's not right. Can you tell me, are you seeing something that shows coming meetings and events?
Yep.
Okay, so we do have some other things coming up. Our One Person, One Vote committee will be meeting on November 10th. That's the group that's looking at the Electoral College and trying to help voters understand what that means, and its implications for our whole political system. We also have next month, a book discussion will be our general meeting. It's on who is government. And Eileen Easterbrook, who's here today, she will be leading that discussion. And you don't have to have read the book to come and learn from the discussion. So consider that. And then we also have our Observer Corps. We'll be meeting as a group. We're just checking in to see how things are going with the Observer Corps. We just started. So if you're interested in attending a local meeting and learning more about kind of your government, it's a very good way to do that. And we're also going to be discussing a speaker for the next kind of group meeting, and maybe somebody who organizes local meetings or something like that. So that will be November 17th. just before Thanksgiving. And then we have new member orientation on Thursday of that week. So if you know somebody who's interested but would like to know a little bit more about us, or if you're, I know many of the people on this call are very familiar with our league, but if you'd like to learn a little bit more about us, come to orientation. It's a great way to kind of ask your questions and get to know some people. So that's some of the upcoming meetings that we have going on. Oops.
And both men and women are welcome to join in that orientation.
Actually, anybody. Absolutely. Bring your dog. So, also, we have some things. We always have lots of ways to get involved. In particular, I'd say voter service is often popular, and probably early next year, we'll be gearing up for the midterm elections, starting with the primary in March. So let us know if that's something you want to do. We do a lot of work on registration, but also really voter education through a lot of different means. So there's that. We have a local study that's going on looking at government transparency and accountability. We're looking at the financing and how transparent it was in the 2024 election. And we're beginning to wrap that up, but it can be a great way to learn about that if that's something you're interested in. We also are looking at, this is a little bit counterintuitive with the current election that's going on, but a independent redistricting commission for San Mateo County, which currently is not the way districts are drawn in our county. The program committee, that's the group that puts on these events. I think they do an excellent job. It's why we can do these things. If you're interested in helping us, either find speakers or help put together copy for the newsletter and the website about programs, or helping us technically get the website, the webinar up and running. All those are roles that we need help with. I've already talked about Observer Corps and our group looking at the Electoral College. And then just lastly, there's a lot of work that we need help with. And if you didn't find something that was really interesting to you, or you have a special talent, let us know about it, because we can probably find a way for you to contribute. And then just the last thing I wanted to speak to is don't forget to vote. There is an election going on. We've had 2 special elections in the last year, and hopefully we'll just be back to regular midterm elections for next year. But don't forget to vote. Proposition 50, you should have ballot materials that you've received. If not, look on our website or contact the county clerk to get more information about how to vote. And with that, I'll just say thank you to everybody for coming, and especially thank you to Mark and the folks from Caminar Health who helped us with this program. I learned a ton and it was super valuable. So thank you.